All right. Good morning, everyone. I'm Meg, and we're going to talk about ECMO today. This is a very structural talk. We're going to talk a lot about the machine itself and how it provides different kind of support, and a little bit less about patient selection and things like that. We'll have to talk about that another day. But to start us off, Dr. Krell, who is this? How do you know? Yes, this is this is Dr. Robert H. Bartlett. He's known as the father of ECMO. Seriously. So the history of ECMO really starts long before Dr. Bartlett, because the history of ECMO is really the history of cardiopulmonary bypass, which was already being used in the operating room by the time Dr. Bartlett was a resident. But like Dr. Krell said, he was very influential in the intensive care world and is really the father of modern ECMO as we know it now. And so Dr. Bartlett was a resident at Boston Children's Hospital in the 1960s. And at that time, the mortality for rate for complex congenital heart lesions for NICU babies was 50%. But they knew that if the babies could survive past the first day or two beyond surgery, they would do okay. They just had to get over this myocardial stunning that was happening in the operating room. And so Bob, that's Dr. Bartlett's first name, and I feel like he would be okay with me calling him that. Bob asked his chief resident, why couldn't they just keep the babies on the heart-lung machines for a little bit longer after the operation? And so his chief was like, obviously that would never work because there's all these complications with the machine and the blood hemolyzes. But like a good chief resident, he looked at his junior resident and he said, why don't you work on that problem? And so heart-lung machines used in bypass at the time were using something called a bubble oxygenator, which, as I understand it, was a machine that literally just introduced bubbles of pure oxygen into the blood as it was circulating extracorporeally. And so Bob was kind of working with those kinds of oxygenators, and then he goes to this conference and he sees this other guy presenting whose name is, I kid you not, Phil Drinker. And so Phil presented his research, which showed that blood wouldn't hemolyze if it wasn't in the presence of oxygen. And so Bob and Dr. Drinker joined forces, and they used this stuff that had just been invented called silicone to make a membrane oxygenator that allowed for diffusion of gases without instilling the gas directly into the blood. And now, so there were some other labs at the same time who were doing the same thing. And the first person who was actually successfully cannulated and decannulated from ECMO was an ARDS patient. He was a trauma patient, and he was cannulated by this guy named Dr. Hill, and that was happening in another lab. But Bob's story is more interesting, so I'm going to continue with that one. Fast forward to 1975, Bob has now finished residency. Now, mind you, he had finished his general surgery residency. And he goes and moves out with his friend to this hospital in California, where they're the only two surgeons in the hospital. And so they basically are doing whatever they want out there. And they're working on their oxygenator all the while. And they get a call from the NICU that there's this newborn baby who's, in refractory hypoxemic shock. And you might be thinking, why are they calling the surgeons for this? But a lot of these babies who were hypoxemic, it was because they had a PDA at that time, and we didn't have like prostaglandin inhibitors and all that stuff. And so the surgeons would go in and ligate the PDA. And so Bob and his friend go and see this baby, and she's horribly cyanotic, and her, SAT is like in the teens. And so they're like, this baby's about to die. We should try to put her on our machine. And so they go to this baby's mom and they're like, we got this new machine. We haven't really put that many people on it. We don't really think it's going to work that well. It might hasten her death, but we want to try it. And so this mom was a teenager from Mexico. She had just crossed the border to give birth to her baby in this hospital. And she is like freaked out. There are all these people in the room now. There's all this hubbub. She's worried she's going to get deported. So she leaves her baby there. So naturally, Bob's like, what's the next step? I'm going to cut down on her vasculature in her neck and put her on VA ECMO. And so that's what he did. And the nurses nicknamed this baby Esperanza because that means hope in Spanish. So anyway, the ECMO works, corrects her hypoxemia. Now Bob and his friend are like, okay, let's figure out what's going on with this baby. So at the time, like I said, all these babies, or a lot of these babies who were cyanotic, had a PDA. So that's what they suspected. But they didn't just have like an echo to figure out what was going on. And so they injected dye into her arterial system, and then they could watch and see where the dye went. And that would tell them if the PDA was open. So they expected to see all this dye end up in the vasculature in her lungs. But it went the opposite way. And so they were like, this stuff's going from right to left. This doesn't make sense. So they're like any good surgeons, they don't trust their test. And they're like, let's just go to the OR and see what's really going on. So they open her up, and sure enough, they see this big patent ductus arteriosus. And so they're like, well, I guess we should ligate it. That's what we usually do. And so they do that. Now, what was really going on with this baby is that she had persistent pulmonary hypertension in the neonate, which is a very complicated problem with a lot of different theories about why it happens. But basically, these babies have persistent fetal circulation after they're born. And we realize now that it gets better within a few days if you can keep the baby alive during those few days. But Bob didn't know this at the time. And so they ligate the PDA, and they're just like watching, and all of a sudden her pulmonary artery is like getting bigger and bigger. And they're like, that's weird. And so Bob, obviously this baby would have died if she wasn't on ECMO. But Bob's like, I wonder what the pressure is in that pulmonary artery. And so he puts a little catheter in there and measures the pressure, and it's double the systemic pressure. And so he's like, ooh, I do not know what's going on. The heart looks structurally normal. There's no good explanation for this. He's like, there must be got something going on in like the microvasculature of her lungs or something like that. But regardless, I don't know how to fix it, and this baby's going to die. I don't want her to die in this operating room. So they're like, let's bring her back to the ICU. And tonight I'm going to go into a room in the middle of the night, turn off the ECMO, and then the pathologist will tell me what's wrong with her lungs. But then he gets there that night, and he notices that her PA pressure is like a little bit better. And so he waits, and the next day it's like a little bit better. And eventually she gets better, and he takes her off ECMO. Now, a little aside, when he goes to take out his little, pulmonary artery catheter, he takes it out, and it's like 4 centimeters shorter than it was when he put it in. And he's like, ooh. So he gets a chest x-ray, and sure enough, 4 centimeters of that catheter is broken off and is now lodged in the right lower lobe of her lung. And so he and his friend now have this like healthy baby who's off ECMO, and they're like, what do we do about that? But she's doing fine. So they're like, we're just going to leave it. We're not going to worry about it. So she gets adopted by her foster family, who's been, visiting her during this whole process, and they move away, and Bob and Esperanza lose touch. And then 14 years later, Bob gets this call. He's now living in a different state. He's not working at this hospital anymore. Gets a call from a pediatrician in Missouri who's like, I need to talk to you. I am talking to this girl. She's like, I don't know, 15 years old now. He's like, I'm talking to this girl, and she and her family are telling me the story that I cannot believe. He's like, she has a left thoracotomy, well-healed scar. She has a scar on her neck. And I took an x-ray, and she has a little piece of something lodged in her right lower lobe. And so Bob Bartlett said, thank you very much. I've been looking for that little girl. And so this is them at an ELSO conference, years later when they reconnected. Okay, enough storytelling. Whew. We're going to go through the basis of the circuit first, and then we're going to talk about the different configurations, because essentially the circuit and its pieces will be the same, and then they can provide different support to patients based on where you put them, i.e. if you put the reinfusion cannula into a vein or if you put it into an artery. So lots of pictures, because I think that's the easiest way to understand ECMO. So this one shows over here the air and oxygen coming in, usually from the wall. Those big yellow and green tubings connect to the blender. And then the blender is where you physically turn the knob to titrate the sweep. And this is where it gets a little bit confusing, because there is gas flow, which is the flow of the gas across the membrane. And that's the sweep. So when we titrate the sweep, we're controlling how fast that gas is moving across the membrane. And then there's blood flow, which we just call the flow. And that is how, we're actually controlling the revolutions per minute that the pump is making. And that's how we affect oxygenation, by adjusting the revolutions per minute of the pump and how fast the blood is flowing. So if you increase the blood flow across the membrane, you improve oxygenation. If you increase the sweep or the gas flow across the membrane, you can improve CO2 removal, and that helps with ventilation. This is another diagram that I think is helpful. So if we start over here again, we see the blender, and that's where the gas is coming through. The FDO2 is has a knob on the blender as well. The FDO2 is the fraction of delivered oxygen. So this number is analogous to the FiO2 on the ventilator, but we just say delivered instead of inspired because the machine isn't breathing. So FDO2 is kind of debated in the ECMO world a little bit, and there are different theories about what we should do with the FDO2 and whether or not we should titrate it down when we're weaning people off ECMO, and some centers used to do that a lot. I think most centers that we're at now just keep the FDO2 at 100%, which is what we do here. And then if we want to adjust the oxygenation, we adjust the blood flow like we were talking about. This makes sense to me because, you know, especially with a brand new oxygenator, it's like a really, really good lung. So even if the, you know, FDO2 is room air, you should be able to 100% saturate the blood, you know, as it passes across the membrane. This gets a little bit trickier as the oxygenator, you know, gets a little bit older, clot builds up on the membrane. It might not be as efficient, but that's kind of a conversation for another day. So from the blender, the gas flows into the oxygenator where it meets up with the blood flow. And so from a blood flow standpoint, the drainage cannula pulls blood from the venous system using this pump, and then that feeds it into the oxygenator. So in most systems, there are pressure sensors and saturation probes on either side of the membrane. So these probes measure a pre-oxy pressure as well as a post-oxygenator pressure. And then the difference between those pressures is the pressure gradient across the membrane. And a lot of people just say delta. And so if you hear people talking about the delta, that's that pressure gradient across the membrane. And over time, that delta is going to rise. Clot and fibrin is going to build up on the oxygenator, and that pressure gradient is going to go up. A slow increase is okay, but if you're watching these numbers and it starts going up really quickly over the course of a day or a few hours, then you might worry that the oxygenator is in danger of failing, that clot's building up really quickly, and then you might change out that portion of the circuit. Yeah. So it depends on the circuit and the patient and everything like that, but generally you're looking at pressures in like the 200s. You don't want it to get, you know, really into the 300s. And then the delta is interesting because it really varies patient to patient. And so you really have to trend it, because when you put someone on their delta, you know, some people's delta might be like 8, but some people's delta might be like 30. And like both of those are okay. You just have to, you know, watch the difference and how it changes from day to day. And then in addition to measuring pressure, we can also measure oxygen saturation before and after the membrane. So the oxygen saturation after the membrane should be what? Yeah, 100%, right? And then the oxygen saturation before the membrane is probably going to be like 70s, maybe 60s, maybe 80s sometimes, which we'll talk a little bit about. And so those numbers you're always watching, and that can help clue you into when there are some things going wrong with the oxygenator. So a brief word on the oxygenator itself. It's made up of these hollow microfiber tubules, and the gas flow travels within the tubule, and then the blood flow kind of travels around the tubule, and the diffusion of gases is happening across the membranes of each of those little tubules. And then this also shows the water flow, and we can use the water to help kind of try to control for the temperature of the flow. This is really more for warming the blood, and so that, because obviously depending on how long your tubing is, that blood's traveling outside of the body, it can get cooled by the time it gets back to the patient. It's not really, people tend to think that we can like cool the patient if they're febrile. It doesn't really work like that. But we can warm them, and we can keep the blood basically at a physiologic temperature. Okay, so like I said, we can take this basic circuitry and we can provide different kinds of support. And so the most basic way to think about it is that VV provides respiratory support and VA provides circulatory support, provides heart support. And so here I listed some of the indications for VV ECMO. The one that we deal with the most is ARDS. And so I listed the inclusion criteria here from the Eolia trial, which is generally the criteria that we think about when we're deciding if someone needs ECMO. So essentially what we're saying is a patient might meet criteria for ECMO if 1, they can't oxygenate despite maximal vent support, 2, they can't ventilate despite maximal vent support, or 3, their numbers actually look okay, but the stuff we need to do to the ventilator to get them there is prohibitive. So we think that the vent settings that we're providing could be harmful to the lungs, and we think that it would be better to put them on ECMO so that we could turn down those ventilator settings and risk future damage. VV ECMO does not affect hemodynamics. So sometimes people get confused because, you know, we may be flowing 5 liters per minute and we're pumping all that blood like seemingly right at the RA, and people think like, oh, this must be increasing your preload, this must be, you know, you're going to like overflow the RA and go into right heart failure. But you have to remember that whatever you're putting in, you're also pulling out from the IVC right below, and so the net is 0. And so there's no effect on hemodynamics with VV ECMO. And so that will be contrary to VA ECMO, which we'll talk about in a second. This is just showing a couple different VV ECMO configuration. During my training last year, I mostly did FEM-IJ VV ECMO. I think here we do a lot more FEM-FEM generally, but it's really just kind of provider preference. And then that other photo is showing the Avalon cannula, which is a dual lumen cannula. And basically, it has, you see that blown up picture over there. It has drainage from a portion of the cannula that's sitting in the IVC and drainage from the portion of the cannula that's sitting in the SVC. And then there's another lumen that's providing the reinfusion, and it's coming out through the middle of those 2 drainage portions. And you have to direct that hole, you know, at the tricuspid valve. And so you need to use fluoro to put this in to make sure that it's directed in the right direction. Otherwise it'll just, you know, be flowing down into the IVC and you'll be recirculating. So recirculation is a specific VV complication that I want to talk about. So just ignore the hemorrhage and all that. What I want you guys to focus on is cannula placement. So this is our cannula here. This is our reinfusion cannula in the IJ, and this is our drainage cannula that's, you know, sitting in the IVC. And as you can see in this photo, it just kind of looks like one big cannula. So these cannulas are probably a little bit too close together. This was my handiwork. So when this happens, and honestly, this patient was probably okay, because with a drainage cannula, this is a multi-port cannula, and so it has multiple holes in it, and these cannulas will preferentially drain more distally. So really, most of the drainage was probably happening down here, and reinfusion was happening up here. So it might have been fine, but if it's not, you'll see it clinically at the bedside, because, you know, the blood in the drainage tubing should be dark blood before it gets to the oxygenator, and then it should be bright red blood when it's being reinfused. And when someone's recirculating, you'll see flashes of bright red blood in that tubing that's being pulled out of the patient. And that might be fine. Sometimes you see that and the patient's well supported and you're like, I'm not going to mess with it, not a big deal. But if your patient is not well supported and you're having trouble maintaining their saturations, this is on your differential. Usually it's because of cannula malposition. So with FEM-IJ, the cannulas might be too close together. They might be overlapping. With FEM-FEM, you know, it's important to position the both of them are going to be sitting in your IVC, and you want the reinfusion cannula to be above the drainage cannula so that the reinfused blood is being shot up here and the drainage cannula is being pulled, you know, from lower down in the IVC. So clinically, this might manifest as someone who doesn't look very well supported. And so you go to the bedside and you're like, okay, you know, their SAT is low. I'm going to turn up my blood flow because I want to increase oxygenation. And you turn up the blood flow and the SAT gets worse. And so this is because when you're recirculating, the higher you're flowing, the more you're recirculating, the less efficient your circuit gets. And so that's when, you know, you're kind of clued in, like maybe this is a cannula position problem and I should adjust. Okay, moving on to VA ECMO. So like we said, VA ECMO provides cardiac support. So this is for a patient who has heart failure or someone who's in refractory cardiogenic shock, which is defined as hypotension with evidence of other end organ damage despite lots of pressors. So on the cardiac side of things, this might be an acute MI or a patient who just underwent some kind of reconstructive heart surgery. And so VA ECMO, like VV ECMO, is providing that oxygenation ventilation support that we talked about, but it's also providing hemodynamic support. So adjusting your sweep will still adjust ventilation, adjusting your flow will still adjust oxygenation, but adjusting your flow will also adjust blood pressure. And so in a patient whose heart isn't working at all, you're flowing the blood in its retrograde flow up the aorta. And if your heart's not working, it'll go all the way around the arch. Now, that can be a problem in and of itself, because if the aortic valve can't open, then the heart's going to fill up with blood and you might have to vent them with something, but that's kind of not what we're talking about here. But if that's the case, then as you turn up the flow, you'll turn up their blood pressure. Turn down the flow, you turn down their blood pressure. And so that's how we kind of control their hemodynamics while they're dependent on the machine. Gets a little bit trickier if the patient has cardiac output that is significant, because then increasing the flow can actually increase your afterload and affect the hemodynamics in that way. So it can actually paradoxically decrease your blood pressure, but that's a little bit more complicated than we need to get into today. So you'll notice that pulmonary embolism is listed as an indication for both VV and for VA ECMO. And this really is depending on how big the clot is and where it gets lodged. So it can cause different kinds of problems depending on both of those things. So if it's a large clot obstructing blood flow from the RV, then obviously this is going to lead to heart failure, and the patient's going to need VA ECMO to maintain perfusion to other organs while you get them to, the cath lab so they can do some angiovac, or they get a TPA catheter or something like that. If the clot's smaller and it goes into smaller vasculature and causes a blockage there, then you'll have less hemodynamic consequence. So the heart's still working okay, hemodynamics are all right, but you're going to get some ventilation perfusion mismatch, and this is going to lead to respiratory failure. And so those patients might do okay with just VV ECMO, even in the setting of a PE. So one VA specific consideration that we should discuss is differential oxygenation or differential hypoxemia. So basically, when you initiate someone on VA ECMO, like we said, you're flowing that blood flow. So say we're flowing, 2.5 liters, it's anterograde flow up the aorta. And so if their heart isn't pumping at all, that 2.5, 3 liters per minute is going to go all the way up over the arch and feed all of the branches off of the aorta. However, that's not usually the case. Usually the heart's pumping at least a little bit. And so there's going to be this mixing point where the blood flow from the heart pumping is meeting up with your blood flow. And the blood flow from the native circulation from the heart pumping is coming from the lungs. And your lungs aren't working for some reason. So maybe it's, a parenchymal problem like ILD or something like that, or even your lungs are working okay, but the blood isn't getting where it needs to get. And so you have shunting. And so then again, you have deoxygenated blood being pumped by the heart. And so depending on where that mixing point is, some of those branches coming off the aorta are going to be fed by deoxygenated blood. And this can be a really big problem, because what are some of those first branches off the aorta? True. Yeah, exactly. So heart, brain, like important stuff, right? And so this is why we stress when we're putting someone on VA ECMO that you need to be measuring their pulse ox on their right upper extremity, and you want to be drawing your blood gases from their right radial artery. And this is because depending on where that mixing point is, the left arm might be getting pure, oxygenated, wonderful blood from your ECMO machine. And so a sat on that hand might look great, but then your brain is actually seeing 70% sat or something like that. And so because of the subclavian takeoff, we know that that right upper extremity is seeing probably whatever your brain's seeing, if not a little bit worse. And so if we're measuring and titrating based on that, then we know that we're doing a good job perfusing the brain. Okay, so we can't, unfortunately, talk about peripheral VA ECMO without talking about distal perfusion cannulae. So when we put someone on VA ECMO, we're putting this big cannula into their artery. And so if someone has a nice big artery, then that's fine. There's, the retrograde flow coming up the aorta, but then there's also flow going around the cannula down the leg. But most of the time, especially in my patients with ILD, they have autoimmune stuff and their vessels are terrible and they're really small. And so when you put that big cannula in, you might cut off blood supply that's going down to their leg. And so we put in one of these distal perfusion cannulas, which is a smaller cannula. This one's actually just like a central line, that green you will recognize. But it is going anterograde down the leg. So it's either sitting in the SFA or maybe the common femoral if you have enough room, distal to where you put the first cannula. So these can be really difficult to put in. I mean, if you imagine you put someone on ECMO when they're like arresting, and then now you've stopped all blood flow to their leg and you have to put a cannula in this vessel that has no flow through it, it can be very challenging. So especially in centers where they routinely put DPCs in everyone, if you're planning for that, you can put a wire in the SFA first, and then you at least have that access. We didn't put DPCs routinely in people. We just waited to see if they need them. I don't know if what we do here, but we would just, put them in and kind of hope. And then we could measure leg saturations, and obviously you do a Doppler exam after and make sure that you have blood flow through the leg, but it can be a very challenging problem. Okay, so in addition to standard VV and VA ECMO, you can also have some hybrid configurations that are based on what a particular patient might need. We won't go too much into this because it's a little bit complicated, but you might see some of these in some ICUs, and this VAV configuration actually ended up being a large portion of my practice because Columbia is a lung transplant center. And so, we would often bridge patients to lung transplant if they got too sick while they were on the list waiting. And so this concept of bridging, again, we didn't really get into patient selection, so we didn't really talk about this, but when you are deciding whether or not to put someone on ECMO, you have to have an end game, right? And so you have to have some goal that you're working towards. And so with some patients, that might be recovery. You might think, with those babies with the, persistent fetal circulation, like we know if we can just buy them a little time, they'll get better. And so those patients are a bridge to recovery. And that's usually what we're working with ARDS. We're like, okay, if we just give the lungs enough time, this inflammation will go down, things will get better. So that's a bridge to recovery. There's also a bridge to intervention. So with, cardiac patients, you might say like, we just need time to get them to the cath lab to revascularize them or to get them to the OR. And so that's a bridge to an intervention. And then there's also patients who were bridging to transplant. They're on the wait list and they're, running out of time. And so for my patients, they had ILD. So often they would have secondary pulmonary hypertension. And so they need the VV portion because the parenchyma of their lungs is kind of garbage. And then they need the VA portion because their right hearts fail. And so it's a little bit more complicated, but just so you kind of have a basis for that. And then my favorite, the additional drainage cannulation. We did this a couple times this past year, and this is actually what a lot of my research is on. And it, as you can see from this photo, is kind of fraught with complications. But essentially, the idea is that in order to oxygenate well on VV ECMO, patients need to flow a certain percentage of their cardiac output. And so when you talk to the perfusionist about, you might ask them what the patient's full flow is, and they do this calculation where they use like the body surface area and cardiac index to determine what is this patient's full flow. But we've kind of just like adapted that to using it for ECMO. It's really more for like cardiopulmonary bypass in the operating room. And so this kind of just gives you an idea of what their full flow might be. But these patients are on ECMO, especially with COVID, for a really long time, and their cardiac output is actually going to fluctuate quite a bit, depending on, are they septic? Are they up doing physical therapy? And so their needs change. And especially with COVID, we found that these patients were requiring like a ton of flow. And like we were flowing in a lot of these patients like 6.5 liters, which is a lot more than we would usually flow. And so we could accomplish it and we could get sats that looked pretty good, but we would have really high flows and then really high negative drainage pressure. So the pressure that the machine is using to pull that blood out. And the theory is that that high negative drainage pressure creates more turbulence, more hemolysis, and then these patients would hemolyze, and the heme would, you know, send them into kidney failure. And it was like a whole thing. So we were like, if you put in another drainage cannula and you splice it into the circuit, you can flow more and you can have less negative drainage. And you can, but you know, then you have to control, because whichever cannula is larger is going to have lower resistance, and so you'll have preferential drainage. So you have to you know, kind of adjust for that, and that's how you get big clot buildup and things like that. So anyway, that's all I'll say about that. The last configuration I'll talk about. What? It just depended on where we could. So most of the time we'd have two sitting in the IVC. We'd do 2 groins. And so that's another thing. At one point we had this COVID guy who had like, you know, 2 like 29 French cannulas, and those fit in the IVC. So it's complicated, but I wanted to briefly talk about central VA ECMO, which I kind of think is the future of especially a lot of these bridge patients. And I think we have this really nifty approach that we were doing this past year, because one of the, you know, so central VA is when you put the drainage cannula directly into the right atrium, you put the reinfusion directly into the aorta. They, you know, we use this a lot in the operating room. And the limitation to this used to be that you had to do a median sternotomy to get that access. And then while the patient's on ECMO, they have to have an open chest. And so if we're bridging patients to lung transplant and they're going to be waiting on ECMO for 2 months, they can't have an open chest. You know, they have to be up, they have to be exercising and moving around and stuff like that. And so a lot of places now are using this little mini anterior thoracotomy technique where you make an incision in like the second or third interspace on the right. You can take out, you know, rib if you need to, if you need more room, but you get the exposure that very, very talented cardiac surgeon needs to see the right atrium and see the aorta. And then we, you know, put purse strings directly on there and can put the cannulas right in there. And we tunnel them out through the chest, usually out this way, because you see hers, we accidentally went down this way, and then that made her clamshell a little bit tricky. But you tunnel them out this way, and then you close up the incision. And so they are walking around and they have a closed chest, but they're centrally cannulated on ECMO. And so it's pretty cool. So that's all that I was going to cover today. Does anyone have any questions?